Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, I'll be discussing the management of the heart failure. So I'll be doing the rapid revision of this particular topic. So in the previous section, I have discussed about the heart failure, that is the etiology, clinical features, and as well as the diagnosis. So in this section, I'll be doing the rapid revision of the management of the heart failure. So what are the goals of therapy whenever you are managing a patient with the heart failure is improvement of the symptomatology. Right? Improvement of the symptomatology. And at the same time, mortality has to be reduced, and even the hospitalizations also have to be reduced. Right? So even hospitalizations also have to be reduced. So that is what is the goal of the therapy. And to achieve this, we have the pharmacological and as well as the non-pharmacological measures as well. So the first part of the treatment is you need to identify what is the underlying cause. Right? You need to identify what is the underlying cause. Is it coronary artery disease? Is it valvular disease? Is it arrhythmia, or is it hypertension? So you should be able to identify and treat whatever is the underlying cause. Because the coronary artery disease and some of the valvular heart disease, they will be causing heart failure with reduced ejection fraction. Arrhythmias will be causing high output type of the heart failure and as well as the hypertension. These two, the other two, they come under the heart failure with preserved ejection fraction. So the first important in the treatment is the lifestyle modification. So in the lifestyle modification, because in patients with heart failure, there is fluid overload, sodium and as well as the fluid restriction is very, very important. Now, how much of the sodium the individual can consume every day? So that is just only 2 to 3 grams of sodium has to be consumed by the individual, and at the same time fluid restriction, that is 1.5 to 2 liters, the quantity of the fluid that has to be consumed by the individual, right? And gradually, if the individual is like symptomatically better and improving, what is being advised is the mild form of the exercise is also being advised. Mild, just a brisk walking, right? That is like being advised. And all these patients, they are at risk of increased infections. So vaccinations for the influenza, right? Vaccinations for the influenza, then pneumococcal vaccine, and as well as the COVID vaccinations. So these vaccines have to be given mainly to prevent decompensation due to infection, right? Mainly to prevent decompensation due to infection, the vaccination has to be given. Now, once you come to this pharmacological treatment, so mainly if you take in case of heart failure with reduced ejection fraction, where ejection fraction is less than 40%, what are the drugs that have to be given? So you need to give the ACE inhibitors or angiotensin receptor blockers, or like angiotensin receptor blocker, neprilysin inhibitor. Along with this, you need to add these beta blockers and mineralocorticoid receptor antagonists, that is spironolactone. So by giving these molecules, what is the advantage is they have mortality benefit, right? They have proven mortality benefit. So what these drugs do is they reduce the mortality. Right, these drugs, they reduce the mortality. And the other group of drugs like what we have is the SGLT2 inhibitors, that is dapagliflozin and as well as empagliflozin. These molecules, they improve the outcome even in non-diabetics. Right, they improve the outcomes even in case of non-diabetics, right? And what is the purpose of giving these loop diuretics, that is furosemide? That is mainly for volume overload symptoms only. So only for volume overload symptoms. What will be these volume overload symptoms? Like either pulmonary congestion in the form of pulmonary edema or systemic congestion in the form of the pedal edema. Next is the ivermectin. So when will you give ivermectin is, see, in patients with heart failure, you need to manage the heart rate at around less than 70 per minute. That is ideal, and that will not increase the myocardial oxygen demand. So the heart rate has to be, right, the heart rate has to be maintained less than 70 per minute. Now, in spite of giving maximum doses of beta blockers, or if there is any contraindication to the beta blocker, what you can give is, you can give ivabradine. So ivabradine should be given if the heart rate is like more than 70 per minute and you are also giving maximum dose of beta blockers, then in such case, you can add this particular ivabradine. But very important is ivabradine should be given only when the individual is having sinus rhythm. If there is arrhythmia, you cannot give this ivabradine. And next important molecule is the hydralazine and as well as nitrates. So the advantage of these particular drugs is they decrease the afterload on the heart, because hydralazine is an arterial vasodilator and even nitrate is also the one which will be causing vasodilatation, and this will decrease the afterload on the heart. That will thereby they are very much helpful in patients with heart failure with reduced ejection fraction. Now this very important molecule is this ARNI, that is angiotensin receptor blocker neprilysin inhibitor. And the example of this angiotensin receptor blocker is valsartan, and your neprilysin inhibitor is the sacubitril. And the name of the trial which has been, right, the name of the trial is the Paradigm HF trial. So it is the Paradigm HF trial which has proved that this ARNI will reduce the mortality and as well as the hospitalization. So this particular ARNI, it also has replaced, right, it has replaced the ACE inhibitors mainly in NYHA class 2 and as well as class 3 heart failure with reduced ejection fraction. And whenever you are giving beta blockers are also the one which will reduce the mortality in patients with the heart failure. So whenever you are giving these beta blockers, which beta blocker is being very much effective? That is BMC. Now what does this BMC stands for? That includes bisoprolol, next is metoprolol, and the next one is the carvedilol, right? So these are the molecules. In the metoprolol, the drug that we need to start is metoprolol succinate. So these drugs, they have to be started with low dose, right? And then gradually you need to increase to the maximum dose, okay? But you need to start with low dose and then titrate slowly, and these drugs have been proven to be improving the survival of the individual. And these beta blockers, they have to be given with great caution, mainly in class 3 and as well as class 4 NYHA. And when the individual is in a state of acute pulmonary edema, beta blockers, they should be avoided. Then followed by that, we have mineralocorticoid receptor antagonist. So examples of this mineralocorticoid receptor antagonist is number 1, spironolactone. But what is the disadvantage of this spironolactone is, this spironolactone is the one which can cause tender gynecomastia. So alternative to this will be eplerenone, right? So alternative to this will be the eplerenone. But these are potassium sparing diuretics. They have to be avoided in the hyperkalemia or the renal failure, right? They have to be avoided in the hyperkalemia or renal failure. So this is about the drugs which are used in the treatment of heart failure with reduced ejection fraction. Then followed by that, we have the heart failure with preserved ejection fraction. In heart failure with preserved ejection fraction, there is no proven mortality benefits. Right? There is no proven mortality benefits, right? And you need to treat whatever is causing heart failure with preserved ejection fraction. Hypertension, you treat it. Diabetes, obesity, so treat that. And whenever there is congestion, you need to use diuretics, right? Whenever there is pulmonary congestion or systemic congestion, that is when you need to use the diuretics, right? And in case of heart failure with preserved ejection fraction, there is no benefit from the ACE inhibitor or angiotensin receptor blocker or mineralocorticoid receptor antagonist. So there is no proven benefit of these drugs on the mortality. And then followed by that, we have the heart failure with mildly reduced ejection fraction. So what drugs have to be used in case of mildly reduced ejection fraction is, you need to use the drugs which are given in the treatment of the heart failure with reduced ejection fraction, right? So in the scenario of heart failure with reduced ejection fraction, the drugs that we give is either ARNI or beta blocker or mineralocorticoid receptor antagonists, that is spironolactone. So they are the drugs which have to be given in patients with heart failure with mildly reduced ejection fraction also, right? So these patients of heart failure with mildly reduced ejection fraction, they share features of both reduced ejection fraction and preserved ejection fraction group. And they often benefit from the drugs what are being used in the treatment of heart failure with reduced ejection fraction. Like you need to use either ACE inhibitors or ARBs. Next is the ARNI, the another important molecule, then beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. So these are the drugs that we give in case of heart failure with reduced ejection fraction, and they are also the one which are used in case of heart failure with mildly reduced ejection fraction. Now, after having discussed about the medical management, next thing is you need to be aware of the device therapy. So in the device therapy, like we have two important devices, that is ICD and as well as the CRT. So ICD, it is like implantable cardioverter defibrillator, where the ejection fraction will be when the ejection fraction is less than 35% and the individual is in the NYHA class 2 to class 3, right? NYHA class 2 to class 3, and more than 40 days post MI, right? More than 40 days post MI. So these are the points for the indication of the ICD, right? And the ICD, what the advantage, it will prevent the sudden cardiac death. Next is CRT, that is cardiac resynchronization therapy. So cardiac resynchronization therapy, when will you place is the ejection fraction of the individual is less than or equal to 35%. And if the QRS is like more than or equal to 150 milliseconds, right? More than or equal to 150 milliseconds. And the individual is in the NYHA class 2 to 4, right? So these are the indications for placement of the cardiac resynchronization therapy. And this is mainly in DCMP patients not responding to medical management, right? So even these drugs have been proven, or this particular therapy, CRT is the one which it's a non-pharmacological therapy that is also been very much proven to reduce the mortality in the individuals, right? And in the scenario of the refractory heart failure, you need to plan for the LVAD, left ventricular assist device. And this left ventricular assist device will be acting as a bridge therapy between the medical management and as well as the heart transplantation. So if the symptoms are persisting despite optimal treatment, then you need to do this, the cardiac transplantation. And whenever you are giving the treatment, what is all that you need to monitor? You need to monitor renal function, because you are giving diuretics where they will decrease the fluid level and they can cause impairment of the renal function. And potassium is what you need to monitor, and as well as weight. So whenever there is alteration of the potassium or worsening of the renal function, you need to alter or titrate the medications to the target doses, right? And even the patient is also advised to have a daily weight check, right? The patient is advised to do a daily weight check, because once you are giving diuretics, the edema component reduces and the weight will be reduced. And at the same time, adherence. The importance of the medications also have to be taught to the patient, and at the same time, the fluid intake. So, like whenever you're monitoring the weight loss that is acceptable is less than 2 kg. But if there is reported weight gain of more than 2 kg in 3 days, then you have to consult the physician immediately. So, this is about the patient education. So, this is the treatment or the management of the heart failure. Thank you very much.